Okay, so for this PowerPoint, we are going to talk about the altered thought process. So we're going to cover closed head injuries, seizures, and strokes. So first up, we're going to talk about the closed head injuries. So closed head injuries lead to concussions, contusions, lacerations, or hemorrhages into the brain. Brain damage may be mild or severe. This is because of a coup-counter-coup phenomenon. This happens when either an accident or whatever, the head hits an object like the dashboard or steering wheel, and it goes into a forward direction, then rebounds quickly backwards. So the brain hits the front of the skull with acceleration and the back of the skull with deceleration. Bruising occurs at two locations of the brain, causing significant brain damage. So a concussion is damage to the gray matter of the cerebral cortex or the brain stem. The brain injury is caused by violent shaking of the brain. Signs and symptoms of this are immediate loss of consciousness, which is less than 5 minutes, drowsiness, confusion, a headache, and blurred or double vision. So this is a little helpful picture for you. So there's signs of concussion and then symptoms of the concussion. And you can see the similarities and differences there. Now when we look at a contusion, we know that a contusion is a bruise, but for a brain, that's a little bit more severe. So the brain tissue itself swells after there's some sort of accident or the child falls and hits their head. And because of that swelling, we see symptoms varying on the area of the injury and the size of the injury. So if a kid slips and falls and barely hits themselves, we may not see anything, but if a kid falls down 5-10 stairs, we'll see more symptoms. And the symptoms are unconsciousness or altered level of consciousness. Sometimes they can even be combative. They can have faint pulses, hypotension, shallow respirations. They can be pale and clammy, and then have altered motor response. So the next thing we're going to talk about is cerebral lacerations. This is actual tearing of the surface vessels in the brain. Leads to secondary hemorrhage. It's more serious than a contusion or a concussion. And the signs and symptoms of this are deep coma from the time of the impact, decerebrate posturing, the pupils are non-reactive, and they can have respiratory difficulties. Now looking at intracranial hemorrhages, this is when bleeding occurs within the skull, obviously. So this is the most serious type of brain injury. It leads to formations of hematomas. The neurological changes are caused by an increased intracranial pressure, which you know we love talking about. It may require surgical removal of blood clots to help. So a hematoma is accumulation of blood. There are 3 types of this for intracranial hemorrhages: epidural, subdural, and intracerebral. So epidural is between the skull and the outer layer, so that little thin area there on the right hand side. Then the subdural is between the outer layer and the middle layer, and that's a little more severe. And then we have intracerebral, and that's within the brain, and that's the most severe. So to talk about increased intracranial pressure again, the CSF function is to cushion the brain and spinal cord against injury. The normal level for this is between 5 and 15 millimeters mercury. Any increase in volume of a component must be compensated for a decrease in another component. So if one of our areas is up, the other has to go down. And then the numbers for this don't really matter, but we have our brain tissue, the blood, and the cerebral spinal fluid. So if our brain tissue increases, then our cerebral spinal fluid or our blood have to decrease to compensate for that. Initially, homeostasis is maintained. When no longer able to compensate, the ICP starts to rise. The common causes for our normal increased intracranial pressures is something you should think about, okay? And these can be as simple as sneezing, coughing, bending forward, anything like that. But the things that we don't want to cause our increased intracranial pressure are brain traumas, hemorrhages in general, brain tumors, and even meningitis. So some signs and symptoms are on page 960 in Burke for you in table 38-2. There's early signs and there's late signs. So the earliest sign of this is a change in level of consciousness. Then we have decreased motor response to commands, fixed dilated pupils, bradycardia, and then we can have widened pulse pressure, which is a very severe thing, and irregular respirations. So you need to know what is considered a late sign and what is considered an early sign for the level of consciousness, okay? So, what is considered a late sign? If you think about our late signs, are going to be more severe. So the most concerning thing is that widening pulse pressure, which is Cushing's triad. Cushing's triad is bradycardia, a widening pulse pressure, which is increased systolic pressure with the diastolic remaining the same, irregular respirations, and this is life-threatening. Vital sign changes are a late indicator. So often, signs and symptoms do not show up until the ICP is increased for some time or if it's a sudden increase. The vital signs are very late indicators, so you can have your altered level of consciousness being your early sign, and then once our vital signs start getting a little out of whack, then we know we're in a late stage of our increased intracranial pressure. Laboratory and diagnostic tests used to determine the cause of altered level of consciousness vary very much. We always check a fasting blood sugar. We want to make sure that the hypoglycemia is not causing the altered states of their consciousness. We can do ABGs. Again, hypoxia can also mimic these signs and symptoms. Toxicology screens are done to make sure drugs are not the cause. Creatinine and BUN are done to make sure kidney function is okay and that our kidneys are working properly, because if they're not, those toxins can cause the same symptoms. Liver, again, the same thing. And we want to make sure the patient doesn't have anemia or an infection. Again, all of these things can cause altered level of consciousness. A CT or MRI are done on the brain to make sure that there are no hemorrhages, to check for edema, hematomas, or even tumors. Cerebral angiography looks at the blood flow, and this is mostly used when there's a stroke to make sure there's still blood flow to an area. And if the doctor is really questioning meningitis, they can do a lumbar puncture, but not always do they do this. They can also do lumbar punctures to drain excess cerebral spinal fluid. So if there's too much of that cerebral spinal fluid in those three components that we were talking about, and that one needs to go down to compensate for the others, they can do the lumbar puncture to help alleviate some of that pressure. Surgical management sometimes is necessary to help our patients. They can do a removal of a bone flap. Okay, so they do this to help expansion and get some of that pressure out. They can also go in and pull out the clots that are causing issues. They can do shunts, and these can be internally or externally to help keep the ICP down and by draining the excess CSF. And then burr holes are done. They're just drilled into the skull to remove a clot, or they can evacuate a hematoma. And you can see the little holes around that star-shaped looking scalp flap there. When we look at our assessment, level of consciousness assessment is very important, okay? So we always do our Glasgow-Coma scale. This is objective for assessing our consciousness of our patients. Generally, we want to know where they're sitting, and then we recheck it very often, okay? So a score of 15 is perfect. That's a perfect person, you and I, walking around, talking, doing the things we're supposed to do. A score of 3 is a minimum. They are totally unresponsive at that point, okay? And then a score of 8 or less is usually in a state of a coma, okay? Decrease in Glasgow Coma Scale is a reason to notify the physician stat. So if you had a patient and their GCS was 14, one off for confusion, because some of our patients are naturally confused, and all of a sudden you're getting a 12 and they're not even able to talk anymore, that is something we need to notify the provider of stat, okay? Remember, when a person is in a deep coma, they are still able to hear you. So we need to talk to the client, not about the client, especially in their presence. So you can look at the table on page 961 in Burke for more assistance in the Glasgow Coma Scale. And this is just an image of one. So you can see eyes, verbal, and motor. Eyes, the highest is 4. Verbal, the highest is 5. And motor, the highest is 6. So the motor is the thing that I think will get everyone a little confused, because if a patient can obey commands, touch your finger to your nose, that's obeying commands, that is a 6. If they're localizing to pain, that's a 5. If they have normal flexion, that's a 4. If you have abnormal flexion, that's a 3. If they're extending, that's a 2, and if they're not moving at all, it's a 1. So when you look at your book, your different posturings fall under a motor. So you need to know the difference between which posturing goes to which number, okay? These are some terms you need to know for levels of consciousness, whether they're fully conscious, they're confused, disoriented, obtunded, stupid, or in a coma. So just look these over, and these are exactly, I took a picture of your book and put it on here. Nursing interventions. So they have plenty of potential complications that we have to monitor for, okay? We have to maintain their airway. We have to watch them, check their vitals, check their level of consciousness all the time. So some things we can do to help them along and do our jobs correctly is making sure the head of the bed is elevated 30 degrees or more. That's going to prevent a lot of things from them, aspiration and lots of stuff. And also it's helping with pressure. So if you understand how pressure works with gravity, it'll make more sense to you, right? Sitting up, you have less pressure on your head. If you're in Trendelenburg, you have more pressure on your head. We're giving them oxygen if they need it, monitoring their respiratory status, turning them every 2 hours. If they need tube feedings, we're doing that. They may have, no gag reflex. They may be in a coma. They won't be able to eat. Do we need to do daily weights on them? Providing them with oral care every 2 hours to prevent pneumonia. Positioning them with pillows. Still doing range of motion. So even if a patient is in total coma, we still need to do range of motion. So, what are some nursing diagnoses for these patients? What are the most important things that come to your mind? Ineffective tissue perfusion should be number 1. Our brain is not getting the supply of oxygen and glucose that it needs, either because there's a hematoma taking up space or because we had some sort of stroke or anything like that. So, ineffective tissue perfusion. And if we need to give them oxygen, we will, to make sure the brain has enough oxygen. The other one is ineffective breathing pattern. Our breathing pattern is obviously controlled by our brain, so we have to monitor respiratory status. And then risk for imbalanced nutrition less than body requirements because they may not be able to eat. Risk for impaired skin integrity, again, bedridden. We need to move them every 2 hours, position them with pillows, all of those things. And then impaired physical mobility because they may be on bed rest, they may not be awake and alert and oriented just like you and I. So again, repositioning and giving them pillows and doing range of motion exercises will help them significantly. Medications I want you to look at on your own. These are on page 962 in Burke. There's corticosteroids, diuretics, antipyretics, anticonvulsants, and H2 receptor antagonists and PPIs that these patients are given. You need to know what medications are in each category, how they are used, what they are used for, and what education items we need to talk to our patients about. We're just going to go over a quick case study to make sure everything's flowing together for you. DG is a 19-year-old male who was brought to the emergency department following a motor vehicle accident in which he was the driver. He was transferred to the neurotrauma intensive care unit with the diagnosis of traumatic brain injury. Multiple family members and friends in the waiting room, and his girlfriend died on scene. The chaplain is also present. So for physical examination, his Glasgow Coma Scale is 4. His pupils are 4 and sluggish. He has decelerate posturing and periorbital ecchymosis. There is clear drainage from his nares positive for glucose. Pretty intense. So then we see they did a CT which showed a subdural hematoma compressing on the ipsilateral ventricle and causing a midline shift. So there's a nice bruise in there that's pushing so much pressure that the midline of our line in our brain is off to the side. So there's a bunch of admission orders for us. So 2 hours after admission, DG is unresponsive to tactile stimuli. The left pupil is fixed and dilated to 7. The trauma surgeon suspects that he has developed an epidural hematoma. What emergency procedure can be done to evacuate the epidural hematoma? A burr hole would be the answer, okay? And we would do this on the side of the dilation of the pupil, okay? And this would allow us to get rid of all the extra fluid in there. So what additions or changes might you see in his care? Because he has deteriorated, he's probably going to be placed on high doses of medications, barbiturates, and also he might have ventilator settings that might be changed to make sure he's being hyperventilated to make sure our brain is getting adequate oxygen, okay? Also, he's probably going to have some mannitol or a hypertonic saline. So if you think back about nursing 1, about hypertonic saline, what would hypertonic saline do in this predicament? I want you to think about that. And then the last question there, what are common complications of traumatic brain injuries? The 2 major complications from this are herniation and decreased cerebral perfusion, which together are bad things, okay? So there's plenty of complications that someone can have. Sometimes the damage is so irreversible that they're stuck with whatever deficits that they've been dealt after this type of injury. So we will usually monitor them and make sure that they are taken care of and hope over time that some of their normal functionality is returned. So now we're going to look at seizures. A seizure is a brief disruption of brain function caused by abnormal electrical activity in the nerve cells of the brain. It may involve all or just parts of the brain. Epilepsy is a chronic pattern of seizures. They usually have no idea why this is happening, but some of the things they've linked seizures to in epilepsy are CVAs, birth traumas, hypoxia, infection, drug abuse, fevers, congenital defects involving the CNS system. So pretty wide range of things. There are 2 classifications of seizures. There are generalized seizures and partial focal seizures. So generalized seizures usually involve both of the brain hemispheres, resulting in a loss of consciousness. There's tonic-clonic seizures and absence seizures. Then the partial focal seizures start in one area of the cortex, and those are simple partial or complex partial. First up, we're going to talk about tonic-clonic seizures. This is the most common type in children and adults. They develop suddenly and follow a pattern, usually preceding an aura, which is an unusual sound, taste, or visual distortion that occurs immediately before losing consciousness, followed by a tonic phase, which is muscle rigidity with arms and legs extended and jaws flexed, or jaw clenched, Pupils are fixed and dilated, and breathing stops temporarily. Then, in the clonic phase, the movements are jerky as muscles alternate between contracting and relaxing. Eyes may roll back, the tongue and cheek biting are common, and frothing from the mouth. So you can see in the A and B photo there, the tonic is the rigidity and the clonic is the muscles jerking. Then following the seizure, there's a postictal period. This is usually 30 minutes, sometimes longer for people depending on the length of the seizure, but they are unconscious or very fatigued. They can have a headache, muscle aches. They can sleep for hours, and most of the time they will not remember what happened. Then in absence seizures, this is usually in children. They appear as though the child is sitting there daydreaming. They have a blank stare, blinking of their eyes, fluttering of their eyelids. Lip smacking is also common. All motor activity in them is stopped. Lasts only 5 to 10 seconds, and usually the patient is unaware of what's going on. And sometimes children can experience this many times a day. If it's untreated, it may go up to 100 times a day. Then, the simple partial seizure is uncontrolled jerking movements of a finger, hand, foot, leg, or face. It may spread to another area called a Jackson march. So the Jackson march is when the seizure starts, let's say, in the right arm, and it moves down to the fingertips. So it kind of just marches along that nerve line and continuously seizes. The patient remains unconscious, and they may experience flashing lights, tingling sensations, or hallucinations, and they last about 20 to 30 seconds. Then, complex partial seizures, also known as psychomotor seizures. This involves repetitive, non-purposeful actions such as lip smacking, wandering, patting, or picking at clothing. It's an altered level of consciousness and confusion that is common after seizures, okay? So they're a little out of it after. And then they may not remember what happened, and then they can have an aura present prior to the seizure activity, and it lasts less than 1 minute. So you can see with all the 4 different kinds of seizures, they have their similarities and then they have their differences. Then we have status epilepticus, which is a continuous period of tonic-clonic seizures in which the client does not regain consciousness. Think about that. Those tonic-clonic seizures that we see in the movies just happening and happening and happening. They usually last 5 minutes or more. That is an extremely long amount of time. It leads to physical exhaustion and respiratory distress. Remember on that slide it said they can hold their breath or not breathe for the time during the seizure. So 5 minutes, really long time. It is a life-threatening emergency due to the depletion of O2 and glucose to the brain, which can lead to permanent brain damage. This can be triggered by an abrupt DC of anticonvulsant meds, acute head injury, or hypoxia. Usually this happens with the people that just decide to stop taking their medications because they've been feeling well for so long, and then they will just go into the status epilepticus. So some safety guidelines are if the patient is in bed, we want to make sure the side rails are up and there's padding on those rails to prevent injury. If the client is out of bed, carefully ease that patient to the floor and move nearby objects and place soft items beneath their head. We never want to leave them alone. We don't restrain patients. We don't put anything in their mouths anymore. We loosen all restrictive clothing, especially around their necks. Turn their head to the side, so if you can roll them onto their side, that would be wonderful. And then we monitor the seizure activity carefully. We remain calm and quiet and make sure we give reassurance to that client. And then ensure they have a good resting period afterwards. So if you see someone having a seizure, you need to make sure you monitor the seizure. Time it starts, length, duration, and what kind of seizure it was. So, breaking things down for our assessment from subjective to objective, okay? Subjective data is the experience prior to the seizure, meaning what were they doing before? Did they have an aura? Those types of things. Objective is the nature Were there sequencing of events? What was their respiratory status during it? Did they have stiffness or flaccicity during their seizure? What was the position of their head and eyes? Did they make any sounds? Were they incontinent of stool or urine? And what was the duration of this? It is important to observe characteristics before, during, and after the seizures. We want to know the exact onset. We want to know exactly which body part that was affected, how it was affected, and then the course of the seizure. Was it tonic-clonic? Were there movements? Did they have amnesia? Okay, lots of things. Then again, for them, lots of medications that people are on. The goal for pharmacological interventions are to suppress the neurological activities just enough to prevent abnormal repetitive firing. So we give them too much, their synapses don't fire, they're slow, they can't answer questions. But if we don't give them enough, they can have seizure-like activity. So we control movements of electrolytes across that neuron membrane, which is a very thin gray line, if you say. This affects the neurotransmitter balance. We give them the lowest dose possible at first, and most of the time it's a lifelong treatment, which a lot of people have to just come to terms with. It may also require more than one medication. So the different kinds of medications you will need to know are barbs, benzos, hydrantowins, phenytoins, and succinamides. Sorry. This table is also directly out of your book. So here's a question for you. You are called to the patient's room by a patient's spouse when the patient experiences a seizure. Upon finding the patient in a clonic reaction, what do you think you should do first? Turn the patient to their side, start oxygen by mask at 6 liters per minute, restrain their patient's arms and legs to prevent injury, or record the sequence of the patient's movements and responses as they occur. Remember, this is saying what should you do first, and we want to turn the patient onto their side to prevent aspiration. Then we want to make sure we're recording time sequence and all the other things, and we could put them on oxygen. But the first thing we do is turn them onto their side. Next, we're going to look at strokes. So what is a CVA? It's a disruption of blood supply to the brain, a brain attack. Brain cells die within about 4 minutes of lack of nutrients and oxygen. A chain reaction of damage occurs within the first 6 hours, and neurons begin to die unless blood flow is quickly restored. So here is an image showing the difference between the two types of strokes, ischemic and then hemorrhagic. So ischemic is when the blood vessels are blocked, impeding flow, and a hemorrhagic is when there's a rupture of the vessel leaking into the cerebral area. So when we break down the two types of CVAs, we have ischemic and hemorrhagic again. Ischemic has two kinds, a thrombus and an embolus. A thrombus is narrowing of that vessel, which can lead to complete occlusion of the vessel by that plaque. An embolus can be broken off, travel, and land in a small vessel, completely occluding also. Then when we have hemorrhagic, there's intracerebral and subarachnoid. Intracerebral is bleeding into the brain, which usually is caused by hypertension. And then subarachnoid is bleeding into the subarachnoid space, which can be from an aneurysm or a bursting of one of those vessels. Some risk factors that are associated with CVAs are their race. African Americans are at a higher risk for this. Hypertension, obesity, diabetes, AFib, atherosclerosis, smoking, high cholesterol, alcohol use with illegal drugs, and oral contraception. When we are assessing a patient that we are assuming that has had a CVA, there's things we have to watch for. You see all the commercials, you've seen it in your BLS classes, but difficulty with speech, they can have visual changes, dizziness, headaches, confusion, motor weakness, seizures, and a rapid change in their level of consciousness. FAST is the new assessment tool that they're using for the media to make it easy to remember. F is for face. So are they having facial drooping? Can they ask them to smile? Do they have a droop on one side? Arms. Can they raise both arms and keep them there? That assesses their motor function. Speech. Are they having slurred speech? And time. They only have a certain amount of time to get to the ER in order to get the certain medications that they need to reverse irreversible damage if they don't. Okay. Diagnostic tests we do are CTs and MRIs. CTs usually first because they're the quickest. And then they can do carotid ultrasounds to see if there's narrowing of those arteries. Cerebral angiography if there's a suspected stroke. MRAs, transcranial Dopplers, PET scans, lumbar punctures, EKGs, EEGs, labs, all of the things. Then some complications that you really do need to focus on and make sure you remember are broken down in your book, honestly, simply. So the different terms you need to know are on this slide for you. So look them up in your book and write them out so you can remember, because there's different kinds of things. So hemiplegia is paralysis on one side. So they have left-sided weakness from a stroke. Well, that's hemiplegia. And then aphasia, that's complete or partial loss of language modalities. There's different kinds of aphasia: expressive, receptive, glottal, dysaria, okay? Different kinds. Neglect is when they are neglecting one side. So if they have a right side stroke and they are neglecting their left peripheral vision, that's how we explain that. Dysphagia, swallowing issues. Hemaniopia is blindness in half or more of the vision field, and ataxia is a lack of voluntary coordination of the muscles. So if you have a test question or a board question that has one of these terms in it and you don't understand what the term means, you will have a very hard time answering the question. So look those up and memorize them. So when we're looking at complications, we can look at right hemisphere versus left hemisphere. The right hemisphere will have difficulties or complications of left hemiplegia. Okay, so if you have a right-sided stroke, your left side is affected. You'll have issues with the left visual fields, perceptual deficits, judgment issues, and easily distracted, or they can be impulsive. Then on the left hemisphere, you'll have the right-sided hemiplegia, right visual deficits. They will have aphasia, impaired intellect, slow and cautious, but they will get highly frustrated easily. And these are in your book also on 973. So some nursing interventions we're going to do for this patient start with the management of hypertension or prevention of hypertension. Often this is left untreated with the exception of a hemorrhagic stroke, which makes sense. High blood pressure, it's going to be more bleeding. Head position, flat head is to assure adequate circulation unless the client has a large hemorrhagic infarction. Then the head is elevated to reduce intracranial pressure. And then fluid volume, we give IV fluids to maintain circulating blood volume. We do drug therapy, so whatever drugs that they may need. Surgery, they can do a carotid endocardotomy. They can remove that plaque or anything from that area to prevent any further issues. And we want to make sure we're repositioning, working with the communication deficits, working with them, using writing or pointing or whatever they can do. Feeding, so if they need enteral feeding, whatever they need, we're going to be doing for them, and then assisting them with elimination. The different medications these patients have are going to be very important for you to remember. They vary differently between the types of stroke, ischemic versus hemorrhagic. So thrombolytics are only for ischemic strokes. The time frame is crucial, so within 3 hours. They don't start on additional anticoagulants for 24 hours. Assess them for bleeding with this, okay? And then antiplatelets, that's low-dose aspirin, clopidogrel. And then anticoagulants are for a thrombic stroke. We'll give those to our thrombic strokes, and we always assess for bleeding. Antihypertensives are given if we need them, all different kinds. Osmotic diuretics are for increased intracranial pressure, usually mannitol or furosemide, and these decrease cerebral edema. So we have to monitor I&O and vital signs. And then anticonvulsants are given to prevent and control seizure activity. So just because someone does not have a seizure diagnosis and they are taking Keppra, it's because they had a stroke and we're preventing seizure-like activities. All right, another case study for us to look at. PD is a 73-year-old man who was admitted to the hospital with right-sided paralysis and expressive aphasia. He had been experiencing periods of confusion, right-sided weakness, and slurred speech for the past several weeks. These episodes were brief and resolved completely within an hour. No treatment was sought. He has a history of COPD, an MI 15 years ago, and AFib. Over the first 24 hours of admission, PD's neurological deficits gradually progressed. By day 2, he has right-sided paresthesia, hemiparesis, and global aphasia. What is probably the cause of this stroke? Most likely it's because he has AFib. We don't know what medications he takes quite yet, but he also has other risk factors for a thrombolytic stroke, and he could have been having TIAs. And TIAs are very interesting. They're what used to be called a mini stroke, and it's a warning sign that a stroke is going to occur. So there could be some sort of thrombus or embolus that travels and gets to a spot and causes a temporary low blood flow to that area and gives us these signs and symptoms of an actual stroke. Then it's wiggled free and it's on its way and it doesn't cause any more issues. But that is a warning sign that something potentially drastic can happen and they should seek help. So he also has dysphagia. Before allowing him to eat, which action should you take first? Check the patient's gag reflex, request a soft diet with no liquids, place the patient in high Fowler's position, or test the patient's ability to swallow with small amounts of water. Well, first we want to sit him up. Even if you check their gag reflex and it's a really good gag reflex and they actually vomit, we definitely don't want him vomiting laying down. So no matter what, we want to sit him up. Then we're going to check the gag reflex. And then I want you to look at some priority nursing interventions for these patients, okay? Pay attention to the things that we are going to need to do, what goals that should be for them, realistic goals, okay? And then what teaching do you want to give him and his family? How can they help him? Nurses in charge of shift report are discussing the care of a patient with a stroke who has progressively increasing weakness and decreasing level of consciousness. Which nursing diagnosis do they determine has the highest priority for this patient? Impaired physical mobility related to weakness, disturbed sensory perception related to brain injury, risk for impaired skin integrity related to immobility, or risk for aspiration related to inability to protect their airway. Remember, this is the one with the highest priority, so his airway is the most important. So he's at a high risk for aspiration related to the inability to protect his airway. A 73-year-old patient with a stroke experiences facial drooping on the right side and right-sided arm and leg paralysis. When admitting the patient, the clinical manifestation will the nurse expect to find? Which clinical manifestation will the nurse expect to find? Impulsive behavior, right-sided neglect, hyperactive left-sided tendon reflexes, or difficulty comprehending instructions. D, difficulty comprehending instructions. So go in your book and look at the differences between the right and left-sided issues that come with strokes, and comprehension is on that side. A 70-year-old female patient with left-sided hemiparesis arrives by ambulance to the emergency department. Which actions should the nurse take first? Monitor the blood pressure, send the patient to the CT scanner, check the respiratory rate and effort, or assess the Glasgow Coma Scale score. Well, first, we want to check the respiratory rate and effort because we want to know if they are able to protect their airway. Are they breathing? So ABCs, then we can check their vital signs really quick and send them right down to the CT scanner. After receiving change of shift report on the following 4 patients, which patient should the nurse assess first? A 60-year-old with right-sided weakness who has an infusion of TPA prescribed, a 50-year-old patient who has AFib with a new order of Coumadin, a 40-year-old patient who experienced a TIA yesterday who has a dose of aspirin due, or a 30-year-old patient with a subarachnoid hemorrhage 2 days ago who's on nimodipine scheduled. We want to see the 60-year-old patient with right-sided weakness who has an infusion of TPA prescribed. TPA needs to be infused with the first few hours of a stroke symptom starting in order to be effective, minimizing their brain injury. The other medication should be given as quickly as possible, but timing of this medication is critical. And that's it, guys. Thanks for listening and happy studying. We're almost done.